Good afternoon.
Good afternoon, sir.
How are we?
We are fine, sir, and you?
Fine. We are also fine. Another week has
Thank
come.
God.
So quickly we have to start because we are late. The last thing we talked about in anatomy area is amniotic cavity. That's where we are starting today. As we said earlier on, when the fetus is in the utero, it's covered with two membranes. One is amnion, one is colon. The amnion is very close to the baby, and the colon is a bit far. That's why we say amniotic cavity. So it lies, the fetus lies in the cavity. So the fetus develops, and the amniotic cavity also expands. As the fetus is developing there, amniotic cavity also expands until the fetus is completely enclosed in the amnion and float freely. Inside the amnion, we have a liquor there. We have a fluid there called liquor amnion. And the body stalk becomes elongated to form the umbilical cord. So we now look at placenta. As baby develops, placenta also develops. And placenta is very important to the baby. It's so important that after delivery of the baby, normally we don't throw the placenta away because you have to examine the placenta and satisfy that there's no problem with it before you throw it away, because there are some problems with the placenta. So we have placenta introduction here in the Greek word meaning cake, and it's published red in color, and the placenta is a temporal organ, and shared by the mother and the fetus. The placenta is a temporal organ. So that's what you should know. In other words, after delivery of the baby, it has no business to be in the mother. So it's a temporal organ. But what it does is it allows exchange of materials between maternal and fetal circulation. And the placenta is also known as afterbirth. Maternal and fetal blood do not mix. You shouldn't have an idea that because the baby is in utero, the blood of the mother and the baby is mixing. No, they don't mix at all. Nutrient, oxygen, and fetal waste will that diffuse across fetal and maternal membranes, or fetal and maternal side. So this placenta has some functions. We have talked about them. It produces a hormone. What is hormone, estrogen and progesterone in pregnancy. 3 months after pregnancy, it starts producing this hormone. But most important, it produces a hormone we call gonadotrophin, gonadotrophin hormone, chorionic gonadotrophin hormone. This hormone is very, very important. You know, sometimes when somebody is pregnant, we ask the person to bring early morning urine for tests. When you send your urine for tests, this is what they test for. They look for chorionic gonadotrophin hormone, woman chorionic gonadotrophin hormone. And this is produced only by the trophoblastic cells of the baby. So if you are not pregnant, you don't have trophoblasts. Therefore, you will not produce this hormone. So it's a very good source of confirming pregnancy. The circulation of the fetus, which links it with the placenta, the circulation depends on the generalization of blood flow by the fetal heart. Fetal heart, when it beats, the blood flows 60 miles per minute, 60 miles per minute. So the maternal circulation surrounds the fetal villi. You know, the maternal circulation surrounds the fetal villi, and it flows, and its blood flows, enters and exits in the intervillous space by way of uterine blood vessels, as in the diagram below. So wherever you see the cord, that is the area facing the baby. And wherever you don't see the cord, that is the area facing the mother. So non-cord area, we call it maternal surface. Cord area is fetal surface. Now, the placenta develops from chorion at 10, it is from 20 to 61.5 centimeters in circumference. What we are saying now, anytime the baby is born, placenta is born, you have to do this measurement, and there's a chart for that. You weigh the baby, and the baby should weigh about 500 grams, and the diameter of the placenta is 20 centimeters, 2.5 centimeters thick, in the center, turning out. So it's like a plate. It's like a plate. You measure the circumference, you measure the diameter, you measure the thickness, and what we are giving you is the length. This is the normal measurement. So as we go along, we see some problem with the placenta, and then you appreciate this measurement. As I said, placenta has two surfaces, fetal surface and maternal surface. The fetal surface, it is next to the maternal uterine wall, that's the fetal surface, the fleshy, and dark red in color due to the maternal blood, the outer below spaces. Fetal surface, maternal surface, is next to the maternal wall and is dark in color. It's covered with thin layer of decidia. Don't forget, decidia is the change of endometrium, and it composed of 16 to 20 lobes. If you want to appreciate the maternal surface, you just look at the football which has been pumped, or you look at the what we call it, a bunch of palm nuts. That's how it is. Each one of them is a lobe. And in mothers, you should have minimum 16, maximum 20. And it's also called cotyledons. And it's separated by grooves. We call it sulci grooves. That something like gutters, but it's not a gutter, it's a grooves, known as sulci grooves. For fetal surface, it's a part toward the fetus in utero, is smooth, shiny, and covered by the amnion. The fetal blood vessels can be seen radiating from the insertion of the cord towards the edge of the placenta. So if you look at the diagram that I'm showing you, you see some blood vessels, radiating. When you take a fresh placenta born, that's the blood vessels you see, and then you have the cord, and that cord will be going to the baby. Now you have placenta. The reason why we don't throw placenta is that sometimes there are some abnormalities of the placenta. So you need to examine the placenta, make sure you are comfortable with it before you throw it away. And if you don't take care, you throw it away when it has a problem, and later on that problem will be manifested in the baby. So these are anatomical abnormalities. There are 4 anatomical. In other words, this abnormality developed when the placenta was developing, and we call it placenta circumvallata, susurrata, bipatata, or tripatata, or fenestrate. Placenta circumvallata, susurrata, bipatata, or fenestrate. These 4 are anatomical. You always have to look at the way they word it, anatomical abnormalities. So we have, what do we mean by susurrata? The placenta is born, and you have another small placenta in the form of a lobe coming with it. that small placenta coming with it is what we call centuriate, and therefore the name centuriata. Small placenta, and they become sometimes because that one is not supported well, it can be dislodged and remain in the mother, and the mother can bleed out of that. Causes postpartum hemorrhage usually occur immediately after birth. That is one thing about centuriate, because when you remove the main placenta and this small one is there, it will act like the baby hasn't finished coming. So the woman will bleed. And so the one it is left there, if not in the hospital delivery, it's left there. What will happen is that the leftover will cause infection to the woman, and that will be very dangerous. A hole in the fetal membrane, when you deliver the placenta, you see a hole in the fetal membranes, in the amnion and chorion, with blood vessels running to it. It indicates that something is left in the woman's womb, and therefore you have to set for it and then evacuate it. Otherwise, the woman will bleed. Then we have circumvallata, another anatomical abnormality. The membranes on the fetal surface are two, and they form a double fold of thick and opaque ring around the edge of the placenta. Instead of them to be hanging, they form a thick. That's if you know the way keloids are formed, they form something like around. These membranes are usually retained. They are not strong after the whole of the placenta has been expelled. And of course, as usual, what will happen is that the woman will bleed. Then we have bipatata and tripatata. This is a placenta with two or more lobes. So centuriate has a big placenta, then small lobe. But bipatata has two small lobes, not a big placenta, with just one umbilical cord attached to it, going in different lobes. It has nothing to do with multiple pregnancy. If you are assisting or you are conducting a labor, you see two lobes coming as one placenta. Don't assume that two babies will come. There's another baby there. But the placenta can be two or three lobes. If it is two, we call it bipatata placenta. If it is three, we call it tripatata placenta. Then you have the last one, the last anatomical placenta, we call fenestrine. And this one, when you deliver the placenta, what will happen is that you see a hole there, window. It's not just like this is suturing where the lobe is removed, but you can see a hole. When somebody is standing on the other side, you see the person. We call it fenestrine placenta. They are all not a good placenta. Then we have a cord insertion. Every baby's cord has to insert in the middle of the placenta. But sometimes not like that. We have velamentous insertion. We have battledore insertion, velamentous and battledore. What is velamentous? Indeed, the cord, instead of going to the middle, it rather inserts itself in the membrane, the amnion and chorion membranes. It's inserted there, away from the edge of the, and the blood vessels pass through the membranes. And when you are delivering placenta in a exerting pressure, it's possible it can get torn. And when it gets torn, the person will bleed. Then you have battledore. The cord is inserted at the edge of the placenta with diffusion of blood. Instead of going to the middle, it goes to the edge of the placenta. And that one too is not a normal insertion. This is dangerous to the fetus, especially if blood vessels happen to lie above the internal os of the cervix, because the membranes containing the blood vessels rupture during labor, and that would be very dangerous for the mother. It will also lead to fetal hemorrhage, especially if it lies below the presenting part. It is then referred to as vesa previa. versus arriving from the presenting part. There can be abnormality if the mother during pregnancy has these following conditions. There can be abnormality to the placenta. If the mother is suffering from nephritis, hypertensive, and eclampsia and preeclampsia. So there can be abnormality. Yes. Tamimu Suhani. Salmin. Tamim, any question?
Please, I want you to talk about the placenta circumvallata again. I didn't understand, please.
Placenta circumvallata, you know, placenta has the two membranes are covering the baby. So the circumvallata form a ring, form a ring in the edge of the placenta. And this one is very dangerous for the mother. That's what hello? Hello?
Hi,
Hello,
sir.
You who were quiet and were you listening to me?
Hi.
Pardon?
No, sir.
So, pardon?
We're still on the class waiting on you.
No, I know. Have you heard of we finished with the anatomy. Were you listening to me?
No, please, sir.
Oh, then please, you have to do that as an assignment, right? Because I finished with that lecture. Let me go back and give you the topics I treated there. Okay? We look at the fetal circulation, placenta, amniotic cavity. That's what we look at. So you have to read, okay? And let me. So yeah, placenta function changes of all these places you have me. Hello?
Hi, sir.
So I've done all these places, so you have to read on your own. Function of placenta, fetal circulation, temporal structures in fetal circulation. I've changed over to where we ended last time in obstetric lecture. Yeah, sorry, along the line you were not listening, you were not getting me. No, that's the problem of online lectures.
Sir, but we thought you were out of line.
Pardon?
We thought you were not in the class again because now
I was here talking plenty, only for me to realize that you were not responding to what I'm asking you to do. So please let's continue. The time is.
Sir, we've been online for about an hour and 30 minutes waiting to hear from you. Our rep said they've called you. You were not answering your call.
Oh, that's so.
Yes, sir.
Yes, please.
Oh, that's too bad. Then I'll quickly go back and then give you the because my phone was not closer to me. I detected it myself. Please let's move. We should not talk plenty. Let me go back to what I just did for you, okay? After all, you are nurses already. You can read on your own. What I did with you, but it's unfortunate you are not getting
So all these places we were listening to.
Pardon? All these places were doing. I started here. Hello?
Hello?
Yes, sir.
Yeah, I started.
Yes,
I'm
sir.
not taking.
All these places were there.
Okay.
Yes, sir.
Yeah, please alert me where you missed me so that I summarize it
Sir,
for you.
please, we reached abnormalities due to disease of the mother.
Okay, all right. Of the placenta, right?
Yes,
Yes,
sir.
please.
Okay, that's fine. So, oh, that's too bad. So, placenta by patata, that is where this is the disease of the mother. Then we talk of, in fact, the function of placenta. You were not with me. Hello?
No, sir.
Yes, sir.
Please, these are the functions, I'm sure: respiration, nutrition, glycogenic, excretory, barrier, endocrine. And then factors affecting the function: age, maternal, developmental. Oh, that's right. So how to detect the abnormality? So take note and then read about that. Umbilical cord. And then I described the umbilical cord and I was telling you of its abnormalities. Battledore and environmentals, we talk under placenta. So the length is an abnormality of the placenta. And then we have long cord and short cord. Each one of them has its own problem. Please read about it. And we have the lipoamine, its function, its source, lipoamine function, and then that one too has abnormality, quantity and color. We have polyhydrominous and oligohydrominous, large quantity and then color. And then I came to breasts, and I've told you that the breast, when you get the breast, the size of the breast does not determine the breastfeeding ability. Small breasts can feed very well, and then the large breast depend upon the structure. And the structure, what determines the milk production is the lobes. Lobes, the minimum is 15, the maximum is 20. And then on the lobes, there are some small lobes to be called alveolar lobes, and they have alveolar which produce milk. So I described the breast for you, the nipples, and then we came to areola, the microscopy where we look at the lobes, and on we go, alveola, and then finally I came and talk of lactation. What influence lactation? Hormone prolactin and oxytocin. When you read, you understand. And then finally, we look at the manufacturing of milk by the breast. And this is influenced by the prolactin and oxytocin. And then we finally landed on fetal circulation. And I said the difference between fetal circulation and the fetal and baby circulation is this structure: ductus venosus, foramen ovale, ductus arteriosus. Ductus venosus is found just after the vein is leaving the baby to leaving the placenta into the baby, and it carries oxygenated blood. When the blood gets to the heart, between the atrium, the two atrium, there's a hole there where the blood passes from right to left before it gets to the main circulatory system. And after oxygen has been removed and the blood comes back into the heart, before it gets down, before it gets to the lungs, it moves out of the main blood vessel and enter ductal arteriosus, which join the aortic arch, and then send the blood down on the way to placenta for oxygenated again. Then when it gets down, it passes through hypogastric arteries, and that sends the blood to the placenta. Remember when we were doing umbilical cord, I said there are 2 arteries in the umbilical cord. So that is where we ended for the anatomy, and I was moving. Before we ended, I was giving you the problem that will occur when the hole between the atrium, the foramen ovale, if it's not closed, it will persistent and the baby will develop hole in heart. The patent ductus arteriosus, the baby will develop hole in heart. And sometimes too, when the cord is cut and it's not properly handled, the baby will bleed, there will be hemorrhage. Unfortunately, I've talked a lot about this thing, and I'm sorry, that is the problem of online lectures. So you go and read. I've given you the topics I treated before you went off. Now, I'm looking at the signs and symptoms of pregnancy. Any comment again? Hello?
Hi.
Okay.
Sir.
Yeah, we are now ready for the next semester. When are we going to do it? If the prefect is listening to me, please give me a date that we will do the May semester and the time. Give me the date and the time before I leave my lecture, because we are asked to do the May semester. Hello?
Hello, sir.
People are not talking. We are not seeing each other's face. So it's very difficult if you are not talking.
This one, I think you should think of the day that you think you can do it, so that you tell us.
And if I'm going to do it, what time will be suitable for you all?
Sir, I think weekends.
Weekend.
Yeah, please. Next week.
Next week or weekend?
Yeah, next week.
No, we can't sacrifice our lecture to do these things. So
Sir,
why can't we find within weekdays and then we do the exam?
Sundays too will be okay. Next week Sunday too will be fine.
Sunday, so I should tell the IT people to administer it on Sunday.
Yeah, I think so. Next week. Not tomorrow, Sunday.
I wonder whether, I don't know whether they will come to work on Sunday.
Sir, they will. Normally we used to do mid-sem on Sundays.
Okay, all right. So then I'll find out from them. If I find out from them,
Sir.
it means this Sunday coming week, we'll do the next semester.
Okay.
Hello,
Okay,
sir.
all right. Yes, madam.
And please, with the time you asked, what time would be convenient for us?
Yeah,
we will be happy.
that's what I was.
If you leave it, maybe if we are using the our e-learning platform, you can maybe leave it there and give maybe some hours. So within that hours, we are supposed to
know
finish
what you are saying. I know everything.
Okay.
Do you understand? But the hours will not be left for the whole 24 hours.
Oh, sir, we are not talking about the whole 24 hours, at least.
Okay.
Some hours.
All right. All right. So I'll get back to you through your prefect.
So, sir, how many questions are we expecting?
Okay.
Let's go on our lecture.
Hey.
Are you with me?
All right, sir.
Yeah.
Yes,
So at the end of semester exams is 2 hours. So mid-semester is 1 hour. So we don't. So it's half of end of semester. But of course, it's going to be objective and essay topic. Objective and essay. And after that, too, I'll give you another assignment to work on. But today, you add into my drawings fetal circulation and placenta. So 2 drawings, fetal circulation and placenta. I'm taking note of them. I'm recording them. When my drawings come and it's not part, you lose marks. So signs and symptoms of pregnancy. When a woman becomes pregnant, some conditions. Yes, Master.
I have a question.
Ask your question.
So, like you were saying, you can't sacrifice your lecture hours for the exams. You know, next week has been slated for midterm. Some of the teachers will also use that hour. So, in that case, what do we do?
I think what we have been told is that in order not to, because of the shortness of the semester, in order not to waste the time, the lecturers can decide when to do their what you call it, their exams. So people will not do it next week, as you were saying. Every lecturer will do it at its own convenience. Okay. Can we continue with our lecture? I'm itching to do this. Presumptive signs and symptoms of pregnancy. What I have here: amenorrhea, morning sickness, breast changes, bladder. These are what we call presumptive signs. If the woman is not menstruating, it does not necessarily mean that the woman is pregnant. If the woman gets early morning and they start vomiting, it does not necessarily mean that the woman is pregnant. If the woman is as you have been urinating often, it does not mean that the woman is pregnant. So these are presumptive signs: abdominal enlargement and the movement of baby in utero. It are presumptive signs. Presumptive sign. Amenorrhea can be due to change of environment, anemia or malnutrition, ovarian and pituitary imbalance. So, or if the woman is taking some pills and they are stopped, menses can stop. So that is not a good sign for pregnancy. Morning sickness, getting up in the morning and vomiting may be due to malaria, due to gastric disturbances, pyelonephritis, infective hepatitis, and then emotional upset can make you vomit. So you can use that to judge the woman that the woman is pregnant. Then breast changes. Some women get breast changes, feeling some tingling sensation, even when they are going to menstruate. So you can use that as well. The woman gets a bladder irritation is another area where they usually conceive frequent or menstruation without pain or burning sensations. So you can use that. Skin changes. Sometimes when a woman is pregnant, when we do the changes in pregnancy, there's something we call pregnancy mask, which is called asthma. Primary and secondary areola, okay, but it may be due to liver disease. The skin changes in pregnancy can also be to exposure to the sunlight. Abdominal enlargement. You get somebody with abdominal enlargement, does not necessarily mean that the person is pregnant. It can be fibroid, it can be tumors. And then this is the fetal movement felt by mother, quickening. That's it's not a positive sign of pregnancy. It's not it's not a positive sign of it's presumptive sign. What about the probable signs? We have changes in utero. 7 weeks, the uterus look like a hen egg. Remember when we look at changes in pregnancy, 12 weeks, 16 weeks, 28 weeks, 30 weeks. When that happens, it's likely to be a pregnant. It's more closer and more positive than presumptive signs. So when the uterus is changing, the Hegel signs is this becomes possible in 6 to 12 weeks. If it is there, then the woman is pregnant. But if it is not there, if it is there, if the 2 fingers are put on inserted into the anterior fornix of the vagina, and the other is placed behind the uterus abdominally. The fingers of them, we have isthmus of the uterus, which is near the cervix. You put your hand and almost raise the vaginal wall at the fornix, and you realize that it's very, very soft. Then it is good to tell you that this woman may be pregnant. And then we have Jacquemin's signs. 8 weeks, this sign comes in. The vagina, it is the violent discoloration of the vaginal lining. You pick the vagina, you put the speculum, and then raise the vaginal wall, and you see the color of the wall have changed. This can also happen when you have cellulitis of the pelvis. So it's not very strong point. And then we have another sign we call Osiander's sign, and 8 weeks onwards in pregnancy. This sign, there's increase in pulsation, lateral fornix. So when you put your hand and there's pulsation, but it also can happen in cellulitis and in tumors. So it's not a very reliable sign. Then you have softening of cervix. Softening of cervix. When the patient or the woman is not pregnant and you do vaginal examination, you touch the cervix, they become very, very hard. The woman responds violently. But if the woman is pregnant, it's very, very soft, and it indicates the pregnancy. Ballotment, you hit the abdomen of the pregnant woman, and if there's something inside the amniotic fluid, it moves to the other side of the uterus, and you feel it with your fingers. It rebounds. Then we conclude of what? Pregnancy. Uterus shovel, it is soft-blowing sound heard on auscultation and strenuous with the mother's pulse. The uterus shovel is also heard when fibrotumors are present. You put the soft-blowing sound heard on auscultation when you put fetal stethoscope, and then you hold the maternal pulse. You see that you hear some sound, It is not very reliable because in fibrotumors, that sound can be heard too. It is said to be due to blood pulsating from the narrow to wider channels, especially the placenta side. And then you have this we call Braxton Hicks contractions. These are painless contractions that from the word go. The woman will be complaining of contractions, painless contractions, of course, and with each uterine contract, deoxygenated blood is brought out from the uterine sinuses into the veins. It also helps you to predict that the woman may be pregnant. But this fetal heart rate, fetal part palpated, fetal movement felt by the mother, ultrasound scan evidence, and prognostic test. All these tests indicate that the woman is pregnant. All these tests indicate that the woman is pregnant. Fetal heart sound, 20th weeks onwards, you should get some sound coming from the fetus, and the heartbeat is 120, 140. If you count this, then it means the woman is pregnant. And then we have fetal movement. If the woman is feeling some movement in the uterus, it means possibly the woman is pregnant. Then if you palpate and you feel some parts, you feel the limbs, the head, and so on, then the woman is pregnant. If you take a scan and you see some image from the uterus, it means the woman is pregnant. If you do prognostic test, which normally is done with the early morning urine, what it indicates is that the woman is pregnant. So, to diagnose the pregnancy, we normally collect the urine of the mother, and we look for chorionic gonadotrophin hormone, which is excreted in the urine of the pregnant woman. And if the woman is not pregnant, you will not get this hormone in the urine. So it's a positive test because it is produced by trophoblastic layer of the fetus. So it's a positive sign of pregnancy. First specimen of the day into the best. So, minor disorders, when a woman is pregnant, it complains of certain problems, and those problems are minor disorders. In other words, they occur because of the pregnancy. When the pregnancy is over, these disorders will go away. So the minor disorders, it is a condition that arise because of pregnancy. They are considered as minor disorders because they are mainly the result of physiological changes occurring in the body, but they are very disturbing. These are the minor disorders which will send the woman to the hospital, and or it will send the woman asking questions. So the first one is morning disorder. Normally, you don't have to get up in the morning and vomit. So when the woman gets pregnant and she gets up in the morning, she's vomiting, it's concern for her. Constipation is one of the disorders and because of the progesterone and estrogen. Constipation is because of the progesterone and estrogen. It relaxes the rectum, and the woman will not attend nature's sport. So she's worried. But it's brought by the pregnancy. So you advise her to take a lot of fruit, vegetables, and fruits, milk of magnesium, and then advise the woman against giving herself enema. That is very dangerous. Also encourage exercises that will let her. When we say to encourage exercise in pregnant woman, you don't accept to be jumping and jumping. The main job that she has been doing before she got pregnant, she should continue, and that will serve as exercise for her. She also complains of backache, and this may be due to hemorrhoids, and constipation. This same woman will complain of heartburns. It's also a minor disorder. It's caused by the progesterone, which relaxes cardiac sphincter, and then acid in the stomach will be hitting the chest. When she delivers, it will go. So you advise her to sit up sometime after meals, sip some milk.
Sir, please, we treated this last week.
Is that so?
Yes, please. I raised my answer right now.
Okay, so
the time is almost going.
The time is almost gone. Okay. Number of visits, effective booking. Have we done that? Booking of patient for the hospital.
No, please.
Yes, please. Oh,
No, yes.
No, please.
Yes.
No, please.
No, please.
No, please. Booking for
Please,
hospital, we
no,
haven't.
no, please.
Please.
Effect of good antenatal care. Have we done that?
No,
No,
sir.
please.
We've done it.
Please.
No, sir.
No, sir, we haven't done it.
No, sir.
Number of visits to clinic.
No, sir.
The antenatal, we haven't done that one.
Next week, I think the time is almost up. Next week, we start with effect of good antenatal care. All right, and then the anatomy part will be pelvis. So go and prepare pelvis.
Antenatal care, we haven't done that one.
Which one?
The antenatal care. So the last week we just stopped at where you were and the lady told you. And the number of visits, all those things, that's what we were to start with, but we didn't.
The number of visits is what we have to start. Please let's set the record straight. Pardon?
And like the antenatal,
We didn't start with the antenatal.
we didn't do that one at all.
You guys are saying we didn't do it.
Are you looking at the changes I'm doing there?
Yes,
Sir,
yes,
last
we are
week we
looking.
did it.
Yes.
No, I
We
think
did it.
I did hear with you people.
Yes, please.
Yes.
Examination of the pregnant woman.
We've done that
Yes,
one.
Yeah.
we reached here.
Yes, I remember we did that. Please let me send because the time is too short. Marital general examination of the pregnant woman. General examination of the pregnant woman.
I think we have to start here. Yeah.
Okay, please. Next week we'll start general examination of pregnant woman.
Yes,
I'm
sir.
going to record that. So general examination of the record woman for OBS and anatomy will be
pelvis.
We will write it down so that when we come, we'll remind you.
examination of pregnant woman. And then pelvis. Next week, pelvis. Next week, pelvis. So we get the end mid-semester examination you'll be informed accordingly. Any concern?
I think the IT people, one of them is in the person is the host, the middle free host. We can just
yeah, he asked me to ask you when we are ready to do the exams, what time, and I'm surprised. He asked me to ask you. He asked me to ask you.
6 p.m.
Pardon?
Sunday from 4 p.m. to 6 p.m.
4 p.m. to 6 p.m.
Yeah.
No, sir. No, sir. Sir.
No,
Sunday,
7 to 9.
Sir, Sunday from 6 a.m. to 8 p.m.
You will go to church.
No, go to church. Let's make it 9.
No,
From 9
from 6
onwards.
a.m. to 6
Please
p.m.
stay online. I'm going to ask him.
From 6 a.m. to 6 p.m. So if you want to do yours in the morning, you do it. If you want to do yours in the evening, you
He
attempt it.
already said he
Yes,
cannot
yes,
do that
yes.
way, my dear. He already
No,
said he
he
cannot do it
said
that way.
he said he will not leave it on for 24 hours.
If you do 2 hours, the whole system will jam up and we all will be complaining.
6 a.m. to 6 p.m. will help. He said he
That
will
is
not
what
leave
he
it there
said
for
they cannot do.
6 a.m. to 6
No,
p.m.
you didn't hear what he said. He said he
My
will
dear,
not leave it on for 24
He said
hours.
it will be on for 24
24
hours.
hours. That's what he
24
said.
hours is different from 12, just a mere 12
24
hours.
hours is different from 12 hours.
Look, you know, most of us were not out, were not in the class again. So he came. That was the time he asked this question, not just now.
Yes, I have been
Yes, but
on the line since the
24
lecturer left.
hours is
I
different
was the
from
one who
12
asked
hours.
that question. He said you will not leave it on for 24 hours. 24 hours is different from
Yes.
12 hours.
12 hours.
Yeah, so from 6 a.m.
This
to
to
6
6
p.m.
is 12 hours.
6 p.m. is okay.
So that's 12 hours. It will do.
We can make it 14 hours from 6 a.m. to 8 p.m.
From 12 in the afternoon to 12 midnight.
Yes, that one will help because of the network issues.
Yeah, we see. Top up 17. No, they balance.
Take note that the IT people cannot be there till 12 p.m. They are not running shifts. So let's make it a daytime because the IT people cannot be there during the night.
6 a.m. to 6 p.m. They are
Exactly.
always there during the night.
The IT people will not stay there. They will just set it up and leave
Yes,
it for us. So
that's what they
that we
do.
can use the network better.
Because when we call for 2 hours.
Hi.
Hello.
Hi.
Hello, sister.
Hello.
Hi. Hi.
Hello.
Yes, we can hear you.
We are here. We can hear you.
We can hear you.
We can hear you, sir.